nerve fiber layer when you cannot detect the damage in the retinal nerve fiber layer because of myelinated nerve fibers or because of papilledema, then you resort to ganglion cell layer. So the ganglion cell layer gives you some clue. See, more than 50% of the retinal ganglion cells, they are present in the macula. So any damage to the retinal ganglion cell will be depicted in the decreased thickness of the ganglion cell layer. And this is composed of 6 to 8 layers and constitutes about 30 to 35% of the total retinal thickness. So in such cases, you detect the changes in the ganglion cell layer. Okay, but there are some limitations of the macular ganglion cell layer measurement in the macula, because the macular diseases are common in the elderly. So it may be some other disease, not the glaucoma, which is causing the damage, such as macular degeneration, diabetic macular pathology, and epiretinal membrane. Macula contains only 50% of the eye's retinal ganglion cells, while the 50% of the macular 50% of the ganglion cells are present outside the macula. So it does not truly indicate all the macular cells. The macular thickness, retinal ganglion cell does not depict it, does not show you the condition of all the ganglion cells. And the health of remaining 50% of ganglion cells can only be gauged with peripapillary retinal nerve fiber layer measurement. So retinal nerve fiber layer measurements is the most sensitive indicator of glaucoma damage. That is the crux of the story. Okay, so coming to the optic nerve head analysis, I will not go into details, but here is the point. This is called BMO or Brooks membrane opening, and from this point to the internal limiting membrane is the nerve fiber layer, or what we call it neuroretinal rim. So we want to assess its integrity. Now there are some programs which give you progression analysis, how the damage is progressing. And you can see with the serial OCT scans that the damage is increasing in each scan, and you can see in graph form as well as in photograph form. So similarly, in the macular ganglion cell layer, you can have the progression analysis. Coming to the OCT angiography, there are different varieties available, and basically we are concerned with the capillaries at the peripapillary end as well as the foveal avascular zone in the macular area. So smaller cup will have intact capillaries at both places, while when the cup is enlarged, there are more damage at the disc and the capillaries are diminished in number, in density. So this information we get from OCT angiography. So in summary, check demographic data, especially date of birth, very important, because all the normative database comparisons are age dependent. Scan quality is important. Poor quality scans have thinner retinal nerve fiber layer and ganglion cell measurements. And face image should be artifact free, sharp and clear, well centered, and the illumination needs to be uniform. The signal strength should be more than 6, and the ocular surface problems and the dry eyes are the most common reasons for poor quality scans. So device should not be placed under air conditioning vents, which can accelerate drying of the patient's eye. So this was about glaucoma. Now we turn on to OCT in macular diseases. As all of us know that the retina consists of retinal pigment epithelium, the photoreceptors, outer nuclear layer, outer plexiform layer, inner plexiform layer, ganglion cell layer, and the nerve fiber layer. And this is depicted in the OCT in the form of these layers. So starting from outside, you have sclera, and then this is the choroid, followed by retinal pigment epithelium, RPE with Brooks membrane, and then interdigitation zone, also known as cone outer segment layer, cost, and then is the ellipsoid zone. This was previously known as ISOS junction, and its integrity is important because once the photoreceptors are destroyed or their outer or inner segments are destroyed, it means the clinically vision will be reduced. So we were looking always at the ISOS junction, which is now called ellipsoid zone. Then is the myoid zone, and this is the external limiting membrane. So these are four hyper reflective layers. I will count again: RPE, cost, ISOS or ellipsoid zone, and the external limiting membrane. And then we have outer nuclear layer, outer plexiform layer, inner nuclear layer, inner plexiform layer, and the ganglion cell layer. And the most important is the nerve fiber layer. And we know that towards the disc, the nerve fiber layer is more thick. So we can identify which eye is right eye or left eye. So this is left eye because the disc is on the left side. On the temporal side, the retinal nerve fiber layer is slightly thinner. And if the nerve fiber layer are equal on both sides of the fovea, then this is a vertical scan, not a horizontal scan. Okay. So these are the 9 sectors of the ETDRS grid, and as you can identify, the central portion is 1 millimeter, and this is the fovea. And these are the pericentral ring, which occupied 3 millimeter of the area, and this is the peripheral portion of ETDRS sectors, which occupy 6 millimeter. So we can detect the thickness of each quadrant and each sector of the ETDR sector. Now, this is the study which shows that with age, the thickness of the fovea and the macula decreases. So at the age of about 50, 259 micron, and 251 micron at the age of 80. So, and this is true for each quadrant and each sector, that the retinal thickness decreases with the age. And similarly for each portion of the macula, this is valid. And in women, the thickness is less than in men. In fovea, for example, in females it is 259 and in men it is 274. So we have to enter the male, whether the patient is male or female, and what is the age when we take the OCT and interpret it. So these are the graphs showing the macular thickness decreasing with age, both in females as well as in males. This is a Pakistani study from Karachi Civil Hospital, and again shows that the male thickness is 294 while female thickness is 284. So we always consider the sex of the patient, and with age it is declining. This is also in Pakistani study. So coming to the macular thickness, any increase in the macular thickness means there is fluid, and we have then subgroups of outer retinal thickness as well as ganglion cell layer thickness. So this is my own OCT with my own machine, and you can see this is 3D 2000 TopCon, and I have compared my findings with Triton, which is swept source TopCon, the latest machine, and the Heidelberg, and you can see there are some differences, but this is within reasonable limits. And you see, if I repeat the findings 284 and 279, there is hardly difference of 5 microns. So these are predictable. There is some variation, but it should not be more than 5 micron. So coming to the clinical findings and OCT findings. So this is the fluid filled cavity. Whenever the macular thickness is increased, we call it macular edema. Now macular edema can take different forms. It can be in the form of a cyst, macular edema may be in three forms. It may be in the form of a cyst, or this may be a subretinal elevation, or it may be a diffuse retinal edema. But macular thickness is important. So on a lighter note, at the end of each report, I always write correlate clinically and computer generated, not requires signature. So this is the importance of clinical evaluation. Never go on the findings of OCT alone. First, you must see the patient clinically and then see the OCT report. But now we are discussing the OCT, so we'll concentrate on the OCT findings. So this is a wider field, OCT, and showing you a disc and macula at the same time. And this is sclera, this is choroid, and the inner layers. So this is also one option available to us. So as I was discussing, this is the central retinal vein occlusion clinically, and fluorescein FFA, and this is OCT showing you subretinal fluids. So this is cystoid spaces, the whole of the macular thickness is increased, and this is serous elevation of the retina. It's separated, the retina has been separated from the underlying RPE. So this is CMO in RPE, retinal vein occlusion. And here we can see there is some nuclear, the cellular proliferation below the retina, and this has given rise to serous retinal fluid in different OCT scans. So this is an example of CNV with macular edema in before, and this is before and this is after. So after treatment, the component, cellular component has disappeared. So these are undulations in the RPE, and this is because of the deposits at the sub-RPE level. These are drusen's. So deposits of lipids, proteins, and mucopolysaccharides which are present in the Brooks membrane below the RPE, and this gives rise to RPE, nodular appearance of the RPE. Now these are the vitreous opacities, and they cast their shadows on the. So the shadows are also cast by the retinal blood vessels. They also have the shadows. So can you detect which one is having a foveal profile? You see, at the fovea, the internal limiting membrane and the RP come together. So at different scans, so this is probably the place where the internal limiting membrane and the RP are coming closer together. So this is through the fovea. These are not through the fovea because the thickness is maintained at each level. So these are the hyperreflective spots which are present throughout the thickness of the retina, and these are the macular exudates. So exudates with retinal edema, these are the pseudocystic, these are the cysts, and the macular thickness is increased, so there are exudates. So this is sort of degeneration and separation of the lamella. You can say the schisis cavities inside the retina, and this is the lamellar macular hole. So this is the proliferation under the retina, and we can see this is a myopic fundus, and there is CNV in the myopic eye. Right. So this is serous elevation of the retina, retinal detachment because of the fluid. So whenever the fluid, the thickness increases, either it is because of fluid or either it is because of cellular proliferation. So this is RP detachment with hyperplasia of the cells. So this is exudates present at the deeper layers and subfoveal exudates in diabetes mellitus. You can see a lot of edema and the retinal thickness at the macular level. So splitting of the retina or retinoschisis and vitreous. And now this is the vitreomacular traction. Whenever there is a pull on the retina, the surface contour is changed, retinal thickness is increased, and there are cysts formation inside the retina. So this is VMA detached highlight. This is in the with the retinal edema. Now this is again fluid filled cavities and subretinal fluid is present. These are the intraretinal cysts and this is the subretinal fluid. So this is a cyst which is only visible because of the OCT, because otherwise in the fundus photograph it is difficult to appreciate. This is a cold toxoplasmosis retinal scar, but this is a fluid filled cavity that we can treat with the two people are waiting and I will admit them. Okay. So myopic retinoschisis, you can see the retinal layers are disrupted. And so again, if we see again, starting from outer layer, this is the choroid, then retinal pigment epithelium, here cone outer segments, then is this layer is previously known as ISOS junction. Now it is called ellipsoid layer. And the fourth hyperreflective layer is external limiting membrane. And then we have the outer nuclear layer, outer plexiform layer, inner nuclear layer, inner plexiform layer, the ganglion cell layer, which we were discussing just a few minutes back, and the retinal nerve fiber layer. And you can see the retinal nerve fiber layer thickens as the disc is approaching, while retinal nerve fiber layer is thin at the opposite end towards the temporal side. Okay, so this is an membrane, epiretinal membrane, which has increased the thickness of the retina and had caused disruption. The subretinal fluid which is present below the. Now this is enhanced depth imaging or EDI function, in which you can see the details. This is the choroid, and choroid is visible is very prominent in EDI mode, but you can see there is loss of the retinal layers and retinal pigment epithelium. Again, fluid filled cavities and diffuse retinal edema, subretinal fluid, and the serous elevation of the retina. So these, now coming on to macular hole, this is VMA. Now the vitreous has separated from the perifoveal area, but it is attached at the fovea. So vitreomacular adhesions. So this is the form of adhesions. Now this is vitreomacular traction. When the surface contour is changed, there is increase in the thickness, and you can see this is called vitreomacular traction. And this is full thickness macular hole, and you can see an area of edema along the margins of the macular hole. So this is a small full thickness macular hole, and with there are cystic cavities, fluid filled cavities, there is edema around the macular hole. So this is a iron tool which is called anvil, and this is being used for centuries for hammering the iron instruments, and it resembles the macular hole margin resembles the anvil. So these are called anvil shape, and you can see the operculum lying separately. So intraretinal edema is very marked, fluid filled cavities are there. So again, anvil shaped, and they are fluid filled cavities. So this is a full thickness macular hole. The previous classification was gas stages, stages 0, 1A, 1B, 2, 3, 4, while now the IVTS classification is limited to VMA, vitreomacular adhesions, VMT without macular hole, small or medium sized, large macular hole, and macular hole without VMT. So you should remember both the classifications. So in this case, this is the epiretinal membrane, which has caused flattening of the inner retinal layer and increased thickness, but the interruption is not there. The foveal tissue are not lost. So this is epiretinal membrane and this is the macular pseudohole. So in this case, the vitreomacular traction is there. The contour has been changed. There is fluid-filled cavity, but full thickness hole is not present because there is just one layer present on top of it. So this is 1B macular hole. Now this is the vitreous has separated, operculum has separated, and this is full thickness macular hole with detached highlight. And there is a macular hemorrhage also. So along with the macular hole, there is macular hemorrhage. And this is the clinical picture, macular hole, subretinal hemorrhage. So now this is a full thickness macular hole. As you can see, all the layers are interrupted. And stage 2 macular hole, break in the roof, cystoid hydration, and the cystic spaces are visible. Now, the macular hole does not have consistent diameter at all the levels. You see here, this is the minimum diameter, and at the base, the diameter is more. So we take the minimum linear dimension. This is one way of measuring it with the help of caliper. Then there is OCTA. As I mentioned, there are parapapillary capillary loops as well as the foveal avascular zone, the foveal capillaries, and we are concerned with them, and these can be figured out with OCTA angiography. There's one more person waiting, and I will admit. Okay. So with the help of OCTA, we are concerned with the disc, capillaries at the disc and the capillaries at the macula. And OCTA detects the loss of the capillaries, and we can know that this is ultra wide field swept source OCTA. So the capillaries at the different levels are detected. There are 4 levels, 4 layers where you can see the capillary networks, and this is the drusen's which are visible at the different levels with the help of OCTA. So this is again loss of the capillary network, and this is an example of branch retinal vein occlusion. So these are not only there are capillary loss of capillaries, dropout areas, as well as the dilatation of blood vessels. A few vessels are dilated, and there are cysts and disruption of foveal avascular zone. So color OCTA is also an option available. So this is the inner retinal flow. Violet is inner retinal flow, and orangish is choroidal flow. And whenever there is flow in the retina, this is yellowish in color. So this is choroidal neovascular membrane that has gone from the choroid through a break in the Brooks membrane in the subretinal space, and it can go into the sub-RP and subretinal space. So this is a thick choroid, and we have fluid in the subretinal space. And these are the clinical photographs. You see hardly visible, just visible on the FFA, and with the help of colored OCTA, you can see how beautifully this choroidal neovascular membrane is visible. CNV. So this is not only there is disruption of foveal avascular zone, but also a dilated point which gives rise to bright spots with microaneurysm. So this is macular hole. And now we come to the end of this presentation, and we'll see how many of you can pick up the findings. So you can unmute and describe and then mute. So what is this?
Sir, it's a vitreomacular traction.
Good. So VMT, vitreomacular traction. And what about this one? What are the findings?
Sir, thinning of retinal nerve fiber layer inferiorly.
Okay, one option. Any other explanation? We discussed yesterday, you have to keep in mind the artifacts. This is the line. This is the motion.
The left hand motion artifact.
Again, a line here. So this is a motion artifact. So look always carefully at the figure and see if there are motion artifacts. Do not rely on these findings. Okay. So what about this one? What are the findings?
Sir, signal strength is less than 6. It is 4 out of 10. So it is not, again not reliable.
Good. So this is a poor quality scan. So do not go on the findings. Just straight away reject it. Excellent. So what about this one?
So it's a full thickness macular hole with
the from it.
Excellent. So full thickness macular hole with
4B stage.
Now is the difficult part. One by one. I will start from the left. So the first arrow is high. First
retinal pigment epithelium, RPE.
Sir, RP group.
Okay. The second green arrow is second hyperreflective layer. And what is that?
Interdigitation zone.
Interdigitation zone, also known as
ellipsoid.
Ellipsoid.
No.
Cost.
And the third is
ISOS junction, ellipsoid
joint. This is ellipsoid
ISOS junction. So this was very taken seriously previously because any disruption in the ISOS zone were clinically found to have decreased VM. Okay, and the
extra limiting membrane, ELM.
Good. So now you are master of OCT. Excellent. So what about this one?
So OCTA angiography showing the foveal avascular zone.
Vascular zone.
So it was a nice meeting and best of luck in your exams, and my prayers are with you, and I hope that this even after passing the examination your sort of thirst for knowledge will continue, and best of luck again. Khuda Hafiz. Assalamu alaikum.
Thank you, sir.
Thank you, sir.